Our next talk is going to be by Dr. Tarah Ballinger, who's in clinical medicine and a member of the IU Simon Cancer Center at IU School of Medicine. And she'll be speaking about her research, Broadening Clinical Care Models for Breast Cancer Interception. And we're waiting for a slide. So come on up, Tarah.
Great, thank you. So as she said, I'm Tarah Ballinger. I'm the medical director of the breast cancer prevention program within IU Health and the IU Simon Comprehensive Cancer Center. So what I'm going to try to cover today is some of the current guidelines for how we might best intercept breast cancer. A lot of that was covered by Dr. Kuhl, so I'll kind of go over how we're implementing that within the IU Health system and some of the research projects, research questions that we've been asking lately. And I'm hoping that by highlighting our clinical population, there are probably some new collaborations that we can come up with this group here at Purdue. So as I'm sure most people in this room know, preventative medicine is hard. Dr. Casting gave one example of that, but it's hard for physicians, it's hard for patients. The motivations and the barriers are very different than in treatment medicine. So as an oncologist, I see patients with cancer where we can follow tumors, we can follow responses on scans. But in the preventative setting, we're not following any specific thing. There's no way to say, oh great, we've done a good job at this, when the success of what we're doing is characterized by a non-event. We're not measuring their blood pressure and saying, oh great, your medication is working. So this is really hard, but I think this is important because these kind of different barriers and motivators are what we need to think about when we think about how to deliver this to human beings who have certain behaviors. So like Dr. Kuhl said, when we're thinking about breast cancer interception in terms of both prevention and risk reduction, it's not one size fits all, and there are a lot of factors that play into this. So just briefly, the most common factors are things we can't control, female biologic sex, and getting older. And certainly there's a lot of hormonal factors that come into play: early menarche, late menopause, childbirth, breastfeeding. Family history plays a big part in this, both for people that have genetic inherited mutations, but also those who do not. So even in the absence of known genetic predisposition, there's something very hereditary about breast cancer. A lot of the risk models that were mentioned earlier are made by using this BRCA-X gene, where we know that there still is something very inherited. There's also a lot of single nucleotide polymorphisms that travel along in families that contribute to this as well. One of the other big factors is atypical breast lesions. So I have highlighted here atypical hyperplasia. So what that means is there are cells that are supposed to line the ducts and the lobules in the breast. If those multiply, get kind of funky looking, they haven't invaded out of where they're supposed to be, so they're not cancer, they can't spread. But what they tell us is that the breast tissue is doing something that's not quite normal. And so we know that after women have had a biopsy that shows one of these atypical lesions, they have about a 30% increased, or a 30% risk of developing breast cancer at some point in their lifetime. We talked about dense breast tissue earlier today. That's certainly a risk factor. Women with extremely dense breast tissue, which is relatively rare, compared to fatty breast tissue, have about a 5 to 6 times increased risk of breast cancer. And that's not just because it's harder to see what's going on their mammograms. It's because they have denser tissue, they have more glands, they have more cells, so statistically, there's more likelihood that something goes wrong and that they can make a breast cancer. And these are all things we can't modify, but there are certainly modifiable lifestyle factors as well. One of the biggest ones is obesity, although that is only consistently associated with increased risk of postmenopausal hormone receptor positive breast cancer. Sedentary lifestyle, though, is associated with an increased risk of breast cancer regardless of being pre- or postmenopausal and regardless of the breast cancer being hormone receptor negative or positive. We also see a dose response with this, so the more physically active someone is, the lower their risk of breast cancer, and that dose response tells us there's probably something causative there. We see the same dose responsive effect with alcohol. The hormone replacement therapy story is very complicated, so I'm not going to go into it today, but that is certainly a modifiable risk factor as well. So again, we have this one size does not fit all when we're thinking about breast cancer surveillance, and so we know that women over a certain risk level are going to be the patients who benefit more from more increased surveillance and certain risk reduction measures. So again, like Dr. Kuhl mentioned, for women at increased risk of breast cancer, current guidelines recommend breast MRI in addition to mammogram. This is the most sensitive test for breast cancer. Typically in our program, we alternate annual MRIs with annual mammograms every year, every 6 months. And the purpose of this is to intercept cancers that are more rapidly growing or would be more difficult to detect on mammogram. And this works really well. A good example of this is in women with BRCA1 and 2 mutations. Those women have about a 70% lifetime risk of developing breast cancer. But if they decide to keep their breast tissue and be followed with this enhanced surveillance protocol, about 95% of the breast cancers that are detected are stage 1, meaning much more treatable and much more curable. So this does work for the purpose of reducing breast cancer mortality as well. Here are the current guidelines in the US for who should be receiving breast MRIs. You can see down there in the lavender that breast MRIs are recommended for women who have a lifetime risk of breast cancer over 20% based on family history risk assessment models. So like Dr. Kuhl mentioned, they focus mostly on women who are at increased risk because of family history, and we'll talk about those models more in a second. The other reason to identify high-risk women is not just about their imaging, but also because all women who are at increased risk of breast cancer should be offered a medication that lowers risk, which is also called chemoprevention. So what I'm showing here is one of the original breast cancer prevention trials. This is NSABP P1. This trial enrolled women who are at increased risk just because they were older or because they had an increased risk by one of those risk models called the Gale model. Here, women took either 5 years of 20 milligrams of tamoxifen daily or placebo. And you can see with about 7 years of follow-up, there was a 50% reduction in the risk of developing a breast cancer event, which was breast cancer or DCIS. When they looked at subgroups, women who had even more family history or those atypical breast lesions I mentioned, those women benefited even more from chemoprevention than the overall population. It's also important to note that while women only take the chemoprevention for a few years, that benefit continues to persist throughout their lifetime. So this is from one of the chemoprevention trials called the IBIS trial. And the reason I'm showing this is because it's important to know that the risk reduction that women get from these medicines in years 0 through 10 is the same as the risk reduction that they get in years 10 through 20. So the way I usually explain this to women is you're traveling on this risk curve where your risk of breast cancer is going up as you get older. If you take a few years of tamoxifen and then you stop, you're now traveling on a lower risk curve for the rest of your lifetime because your breast tissue has had exposure to that medication. More recently, we have had data on something called baby tamoxifen. So tamoxifen, it's a really interesting story how tamoxifen was developed, if you want to look it up and research it a little bit. But tamoxifen was developed in the 1960s as a birth control pill. It didn't work, and it was repurposed as a breast cancer medication. So we never did any of those dose-finding studies. And what we found more recently by doing some window of opportunity trials in breast cancer is that we probably only need about 1 milligram of tamoxifen to inhibit estrogen signaling in the breast, as opposed to the 20 milligrams that we've been using both for cancer patients and for prevention. So this was a recent trial that was completed that enrolled women that were at increased risk because of high-risk breast lesions. They were randomized to get baby tamoxifen, so kind of like a baby aspirin to prevent a heart attack, but this is baby tamoxifen. So they received 5 milligrams for 3 years versus placebo. And you can see here that the risk curve looks very similar to what we see with full-dose tamoxifen. But the important thing is we didn't really see a lot of side effects. So we didn't see the increased risk of endometrial cancer or the increased risk of blood clots that we see with full-dose tamoxifen. There was also a lot less quality of life issues with this medication compared to what we've seen in the other trials with full-dose tamoxifen. These two doses will never be compared directly to each other because that trial would have to be too large because there would be too few breast cancer events in that trial. So we have switched to baby tamoxifen as our standard practice in our breast cancer prevention clinics. And I've only had a couple patients since making that switch a couple of years ago that haven't been able to tolerate the medication. With the 20 milligram dose, it was a lot of people. We've also had a lot more uptake of this drug now with this new data compared to what we used to have with full dose tamoxifen. So we know that there are women out there who would benefit from screening MRIs, and we know that they need to hear about chemoprevention, but how do we actually locate these women? And one of those ways is from what we've talked about a little bit already today, the risk model. So I'm outlining here just 4 of those. There are several others as well, and the factors that play into each one of them. The Gale model is relatively limited because it only takes into account first-degree relatives, so you're missing the entire paternal side of the family. The Bodacea model heavily weights family history, but it is missing high-risk breast lesions. We typically use the Tarah model updated for breast density in our clinics, but none of these models are great in terms of their calibration and discrimination. They're only a little bit better than flipping a coin when it comes to an individual woman sitting in front of you. However, one of the main reasons to do them is because they were the inclusion criteria for a lot of the prevention trials, and these are what insurance is looking for to be able to cover an MRI. And I'll talk a little bit more about that as well. So how do we do this kind of risk modeling in the population at large? The way we're doing it in our system, like the First Lady had mentioned, is in our mammogram sites, we are having women answer the questions and fill out a risk assessment for both the Gale and the Tarah model. And then when they get their mammogram reports, that will include not only a paragraph about their breast density, which is required, but now also will have a paragraph if they're at increased risk of breast cancer, recommending considering a breast MRI. We're doing this at 22 sites right now. You can see them outlined here. At least I tried to guess where some of the cities are, but some of them I wasn't sure about. So this is one of our old high-risk letters. You can see the paragraph highlighted there where women are notified that they might be at higher risk for breast cancer, and then there's a call to talk to their primary care doctor about that, or to call us to set up an appointment in the breast cancer prevention program. We send out thousands of these each year. The response rate to these letters is less than 5%. So we engaged some communications researchers here at Purdue to look at how well this letter was addressing some of the components of health behavior change theory. What we found was that knowledge was pretty low in women who were receiving these letters. The biggest knowledge gap and concern was whether this would be covered by their insurance. Although women believed that breast cancer was a severe disease and they believed that they were at increased risk for it, their self-efficacy to actually make an appointment was low, and their belief that that appointment would matter at all was also extremely low. The vast majority did not intend to make an appointment, even after reading this letter and filling out the survey, and most of them did not intend to even speak to their primary care doctor about this issue. And so what we've done to address those barriers is implement a patient navigator model. So this is our current navigator, Jane Ambro, who is awesome. Some of you may know her. So what we do now is have Jane directly contact women who are identified as being at increased risk for breast cancer in mammography. She fills these gaps we found in the survey by giving them knowledge, explaining to them where they'll go, who they'll see, how long it'll take, how insurance handles this, what they might learn from the appointment, why it's important. Most of them don't know a medication might be offered or that they might qualify for genetic testing. And then she actually makes the appointment while she's on the phone with them. So she really covers all these barriers. And impressively, if Jane contacts a patient, the uptake of an appointment is 50% compared to the 2% that we were seeing with those letters. So this just argues for how much more lay navigation we need in the prevention setting. And that might also address some of the information concerns in other spaces that we've talked about today as well. So we've been keeping a database the past couple years for our patients seen in our breast cancer prevention program, where we see these high-risk women, sit with them, individualize what their screening plan might be, and talk about different prevention measures. In our 3 sites downtown, we also have a site at IU Arnett, but at our 3 sites downtown, we see about 300 new patients a year. This year, we're on pace to see about 500. You can see here the risk profiles of these patients show that we are finding the patients that we need to find. About 65% of them qualify for genetic testing, and of those, 12% are testing positive, so we are identifying a lot of families that didn't otherwise know about their genetic mutation. We recommend MRIs to about 60% of the patients we see, and 40% of the total population actually end up going on to get a breast MRI. We recommend tamoxifen to about half of the patients that we see, and of those, half of them agree to take it, so our tamoxifen uptake rate is about 50%. When we look at this data, though, there's a couple important things to point out. One is thinking about Black women. So Black women are at increased risk for breast cancer, particularly at a younger age. They're about 70% more likely than white women to develop a breast cancer under the age of 50. So if we wait until mammogram to perform risk assessments and look for these women, we're doing a disservice, and this personalized medicine, as it often does, is just further separating and creating more racial inequity. So to address this, one project we're currently working on, which has been funded by the CTSI and the Office of Community Outreach at the Cancer Center, is to partner with one of our local groups in Indianapolis, Pink Forever Ending Disparities. They do a lot of outreach work in the Indianapolis area. And they have a training program for lay navigators. So they have a workforce of about 50 Black women that serve as breast navigators in our community. So what we're doing in this project is identifying Black women diagnosed with breast cancer in our oncology clinics. We are creating a family tree with them and having the lay navigator help them contact first and second degree women in that family so that we can perform a risk assessment on them. We're using one specific for Black women from the Black Women's Health Study, returning that information to them with some materials developed with our advocates, and then navigating them on to the appropriate risk assessment services. So here, we're looking at early implementation outcomes and also looking at the downstream clinical utility of this model, which I'm hoping will be further evidence, again, for the importance of this lay navigation. The other thing we noticed when looking at this data is the average BMI of the patients that we see, which is 31.1. So the majority of the patients that we see in this clinic are obese. I don't have physical activity on here, but most of them are sedentary as well. So a current project that we're developing and going to start next year, which is funded by Peachy, is looking at the role of exercise to influence breast biology. So like I mentioned, we know that physical activity is associated with a reduced risk of breast cancer, but we don't know a lot about the mechanisms for why this is. So what we're doing in this trial is randomizing women who are at increased risk for breast cancer to receive 6 months of an exercise prescription intervention. The exercise is delivered virtually. They will receive that alone versus the other group will receive the exercise intervention plus some habit formation education where we're actually trying to influence them to exercise more based on their breast cancer risk, and I'll tell you a little bit more about that in a second. But in conjunction with the Komen Tissue Bank that you'll hear about next, we are doing breast biopsies before and after this intervention so that we can look at how these health behaviors are actually influencing biology. So here's a little bit more about that conceptual model that was developed with my postdoc fellow that's here on the slide. So again, what we're trying to do is see, can we improve adherence to these lifestyle changes if we actually use breast cancer risk as a unique motivator to get women to exercise? And in conjunction with this, can we then change distal outcomes downstream that we know are associated with breast cancer in the serum and in the tissue. So we're excited about that project that we hopefully will start next year as well. And that's all I have. Thank you guys so much for your attention.
Any questions for Dr. Ballinger? There's an online one. Can you tell?
Who is a contact at IU RNet to see about risk assessment?
So at IU RNet, the program, I can be the contact for that, but the person who's clinically doing it is one of our APPs. Her name's Delaney Baer at IU RNet. Yeah. But we have a population there if you guys are interested in doing research with that group.
This is wonderful research. It's really, really important to do prevention research. And you're right, it's so hard to figure out what the effects are. And I'm really happy you're doing the breast biopsy. That's a wonderful approach to that. Hard to get anybody to do it. Yes, great.